going to make me do so much all over again. Exit. Resume. Oh my God. Well, I probably need it.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Cardiovascular disease strikes men and women in every nation around the world. From sudden cardiac arrest to the disabling effects of acute coronary syndromes and acute ischemic stroke, cardiovascular disease remains a leading cause of disability and death in many parts of the world. Cardiac arrest occurs in both men and women without warning, or within just a few minutes after symptoms appear. According to most recent statistics, in the United States alone, over 500,000 people suffer from cardiac arrest in just 1 year. On average, only 11% survive. We can improve those numbers. In U.S. cities where healthcare providers make the effort to train and measure their performance with the specific intent of improving performance in the real world, survival rates can be as high as 75%. Understanding and activating the systems of care developed by the American Heart Association is crucial to that success rate. Even more important, fulfilling your role as a member of a high-performance team, focusing on timing, quality, coordination, and administration is the linchpin to providing high-quality emergency cardiovascular care. What you do matters. What you learn can save lives. In adults experiencing sudden cardiac arrest due to ventricular fibrillation or pulseless ventricular tachycardia, the heart is quivering but not effectively pumping blood to vital organs. These patients have a much higher survival rate if they receive immediate chest compressions and early fibrillation.
Shocking.
A defibrillator should be used as soon as it is available. If there are 2 or more rescuers present, CPR should be performed while the defibrillator is being attached. When necessary, healthcare providers may tailor the sequence of rescue actions to fit the most likely cause of arrest. For example, in cases involving drowning or other instances where hypoxia is likely cause of cardiac arrest, ventilation becomes much more important than in cases of non-asphyxial arrest. The American Heart Association continues to place a strong emphasis on high-quality CPR. Recent statistics, however, indicate that CPR provided by healthcare providers is often inadequate. To help address this problem, AHA requires the use of audiovisual feedback and prompt devices during training practice and testing, and highly recommends the use during real emergencies for real-time monitoring of CPR quality. So, what is high-quality CPR? First, it is indicated by a rate of 100 to 120 chest compressions per minute, a compression depth of at least 2 inches in adults, allowing complete chest recoil after each compression, chest compression fraction at least 60%, but ideally greater than 80%, avoiding excessive ventilation. Scientific studies continue to link high-quality CPR to return of spontaneous circulation, or ROSC, and to improved survival. High-quality chest compressions maintain blood flow to vital organs, especially to the heart. One way to measure the effectiveness of chest compressions is to monitor coronary perfusion pressure. Coronary perfusion pressure during CPR must reach 15 millimeters of mercury to potentially achieve ROSC. As chest compressions begin, it takes several compressions to raise the coronary perfusion pressure to a level adequate to supply blood to the heart. The higher the coronary perfusion pressure during CPR, the higher the chances of survival for patients. When healthcare providers interrupt chest compressions, coronary perfusion pressure decreases dramatically and remains very low until compressions are resumed. A reasonable surrogate for coronary perfusion pressure is arterial relaxation or diastolic pressure. However, Because coronary perfusion pressure or arterial diastolic pressure measurements are not readily available during a resuscitation attempt, healthcare providers can monitor CPR quality with waveform capnography using an advanced airway in place or a bag mask device. An end-tidal CO2 reading of less than 10 millimeters of mercury suggests that achieving ROSC is unlikely. Providers should improve CPR quality by optimizing chest compressions. To perform high-quality chest compressions, healthcare providers should push hard and push fast. Push hard means the provider should compress the chest to a depth of at least 2 inches. The chest should completely recoil after each compression. If it does not, coronary perfusion will remain low. Push fast means to compress the chest at a rate of 100 to 120 compressions per minute. Chest compression rate is directly linked to improved ROSC and survival rates. However, survival rates decline when compression rates exceed 120 per minute because compressions tend to become shallower as speed increases. It can be difficult to maintain the correct depth at such a vigorous pace, which is why the American Heart Association recommends that compressors switch after 2 minutes, or even sooner if the compressor experiences or shows signs of fatigue. Another characteristic of high-quality CPR is minimal interruptions in chest compressions. Studies demonstrate that healthcare providers interrupt compressions far too often and for too long, in some cases spending 25 to 50% of a resuscitation attempt without delivering chest compressions. Chest compression fraction, or CCF, is the proportion of time during cardiac arrest resuscitation when chest compressions are performed. CCF should be, ideally, greater than 80%. Healthcare providers can calculate CCF using a feedback device or manually by using 2 timers. One timer measures the total code time from code start until code stop or ROSC, and a second timer that measures the total chest compression time. Each time chest compressions are stopped, the timer is stopped. The timer would resume when chest compressions are resumed. The chest compression time is then divided by the total code time to equal CCF. Data suggests that lower CCF is associated with decreased ROSC and survival to hospital discharge. CCF is a measurable goal, one that providers should strive to achieve. In line with this, the American Heart Association cautions providers against spending more than 10 seconds checking for a pulse, assessing the patient, or doing anything else other than chest compressions. Finally, in performing high-quality CPR, the rescuer must avoid excessive ventilation. For arrest patients, appropriate tidal volumes should be approximately 500 to 600 milliliters, enough to see visible chest rise. This is about half a squeeze of an adult ventilation bag. Excessive ventilation can not only cause gastric inflation and resulting complications, but also can increase intrathoracic pressure, decrease venous return to the heart, and lower cardiac output and chance of survival. In terms of defibrillation, we emphasize the fluid integration of early defibrillation within high-quality CPR. Healthcare providers should start chest compressions and use the AED or manual defibrillator as soon as possible for the best patient outcomes. Some EMS systems allow responders to provide a period of CPR while preparing for defibrillation. The AHA still recommends the one-shock protocol for VF and pulseless VT.
Okay. Which is the maximum interval you should allow for an interruption in chest compressions? It's the amount that's the least amount. Go figure. What is an effect of excessive ventilation? Obviously not decreased intrathoracic pressure, not increased venous return, not increased perfusion pressures, yes to decreased cardiac output. Which is the recommended next step after a defibrillation attempt? Resume CPR. Chest compressions is always the answer if it's on the list. How does complete chest recoil contribute to the effect of CPR? It allows maximum blood return to the heart. Thank you very much. Here we go.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in the video do not always use personal protective equipment, such as gloves. The American Heart Association systematic approach includes 3 components once you have established scene safety and your initial impression of the patient: the BLS assessment, the primary assessment, and the secondary assessment. These sequences combine assessment and treatment components for effective resuscitation. When deciding which assessment to use for a patient, start with the step we all do automatically. Visually assess if the patient is conscious or unconscious. This is your initial impression of the patient. You can form a rapid general impression by a quick visual assessment of responsiveness, breathing, and color to determine the urgency of the situation. After determining that the scene is safe, if the patient appears unconscious, use the BLS assessment. After completing all of the appropriate steps of the BLS assessment, progress to the primary assessment for more advanced assessment and treatment. Finally, progress to the secondary assessment. If the patient is conscious, go directly to the primary assessment and then the secondary assessment, which we'll review in a moment. For unconscious patients, you'll follow the BLS assessment. First, check for responsiveness. Tap and shout.
Are you okay?
If the patient is unresponsive, shout for help.
He's unresponsive. I need help.
Activate the emergency response system and get an AED or defibrillator. Depending on the circumstances, EMS providers may need to call for additional responders to assist with the patient. In some settings, the healthcare provider may assess the patient's breathing and pulse before activating the emergency response system. Next, check breathing. Scan the chest to detect if breathing is absent or abnormal. Check for a pulse. Ideally, you should check breathing and pulse simultaneously. If you can't feel a pulse within 10 seconds, start high-quality CPR, beginning with compressions. If you determine the patient is not breathing normally but definitely has a pulse, bypass chest compressions and support the patient by ventilating once every 6 seconds. As soon as possible, attach an AED or defibrillator and, if indicated, deliver a shock. High-quality BLS is the foundation for saving lives after cardiac arrest. If these steps are performed rapidly and well, the patient's chance of survival increases. In fact, the effectiveness of advanced life support measures depends on high-quality BLS. In some cases, BLS will result in ROSC, but sometimes cardiac arrest persists, requiring you to continue with more advanced invasive measures. This is when you should follow the primary assessment and secondary assessment. Another time to use the primary and secondary assessments is if a patient is conscious. You can easily remember the steps of the primary assessment by thinking A, B, C, D, E. Keep in mind that although these steps are listed in progressive order, the resuscitation team often performs them simultaneously. A stands for airway. For unconscious patients, healthcare providers should maintain a patent airway and consider inserting an advanced airway device. Regardless of the device chosen, the resuscitation team must ensure proper placement and use waveform capnography to monitor effectiveness. Conscious patients can often maintain the integrity of their own airway, and healthcare providers need only ensure patency by providing suctioning if needed. B represents breathing. If the patient is not in cardiac arrest, healthcare providers should assist ventilation as needed once every 6 seconds. If the patient does not require assisted ventilation, healthcare providers can support the patient by administering oxygen as needed. C involves supporting the patient's circulation. Attach ECG leads, obtain intravenous or IV access, or intraosseous or IO access. Give appropriate drugs to manage abnormal rhythms, and assess for perfusion issues. You are collecting a wide range of information, including blood pressure, heart rate, and cardiac rhythm. Additional data, such as temperature and glucose levels, may further refine the initial interventions needed. The A, B, and C steps provide a continuous stream of information about the progression of the patient's condition. D stands for disability. This involves checking for neurological function, quickly assess for responsiveness, levels of consciousness, and pupil dilation. A quick tool that can be used to evaluate neurological status is AVPU: alert, voice, painful, and unresponsive. Finally, E involves exposing the patient. Remove clothing to perform a physical examination, looking for obvious signs of trauma, bleeding, burns, unusual markings, or medical alert bracelets. The secondary assessment involves the differential diagnosis. This involves obtaining a focused medical history and searching for and treating reversible causes. You may naturally jump to some possible diagnoses as soon as you evaluate the patient. However, before arriving at a definitive diagnosis, you'll need to assess the patient and gather additional information about the condition. Gathering a focused history of the patient is recommended. Ask specific questions related to the patient's presentation. Consider using the memory aid sample, signs and symptoms, allergies, medications, including the last dose taken, past medical history, especially relating to the current illness, last meal consumed, and events, especially ones that may have led up to the current illness. The answers to these questions can help you quickly rule in or rule out suspected diagnoses. Next, look for and treat the underlying cause by considering the H's and T's to ensure you are not overlooking a dangerous or likely possibility. The H's and T's create a roadmap for possible diagnoses and interventions for your patient. Let's review these now. Hypovolemia is low blood volume. Hypoxia occurs when inadequate oxygen is reaching the body's tissues. Hydrogen ion, or acidosis, is the accumulation of acid and hydrogen ions in the blood and body tissues. Hyperkalemia is an abnormally high concentration of potassium ions in the blood. Hypokalemia is low blood potassium. Hypothermia is when the body temperature drops below 95 degrees Fahrenheit or 35 degrees Celsius. Tension pneumothorax results from an abnormal accumulation of air in the pleural space. Cardiac tamponade is a condition caused by an accumulation of fluid between the heart and the pericardium. Toxins may be best uncovered by a focused history. A pulmonary thrombosis, or pulmonary embolism, is a blood clot from a large vein that breaks off and travels to the pulmonary artery where it becomes lodged. A coronary thrombosis is a blood clot that forms within a blood vessel of the coronary system. Intervening and stopping a patient's downward spiral is the ultimate goal of the BLS, primary, and secondary assessments. The American Heart Association has developed a truly systematic approach that can facilitate optimal care. By following the assessments in tandem with an adherence to the chain of survival, you will more efficiently and effectively assess, diagnose, and treat your patients.
Which action is part of a secondary assessment of a conscious patient? H's and T's that represent a potentially reversible cause of cardiac arrest. Hypothermia.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The following information represents American Heart Association guidelines and best practices for measuring and improving the basic life support skills of the teams you work with. The successful resuscitation of a patient in cardiac arrest requires a coordinated team effort. Effective teams have providers with well-defined roles, and they work together in a dynamic and timely fashion to prioritize and complete critical tasks. The team leader is responsible for coordinating these tasks and ensuring that clinical care is delivered according to American Heart Association guidelines. Delivering high-quality CPR while minimizing pauses optimizes outcomes after cardiac arrest. But because of competing priorities, it can be difficult for team leaders to continuously monitor and provide feedback on CPR quality. The CPR coach is a new role within the resuscitation team, and it's designed to address these difficulties and promote the delivery of high-quality CPR. The presence of a CPR coach allows the team leader to focus on other elements of cardiac arrest care. Whether you are a basic life support provider or an advanced life support provider, the role of CPR coach exists to help you and your team deliver high-quality CPR. The most effective way to implement the role of a CPR coach is with a real-time audio-visual feedback device. We'll discuss some of the functions of the CPR coach and how they use feedback devices. First, let's talk about the team layout when using a CPR coach. CPR coaches should stand across from the compressor, always in the compressor's direct line of sight. CPR coaches should also stand next to the CPR feedback display, which is often located on the defibrillator, so that they can effortlessly redirect the compressor's attention to the data provided by the feedback device. Now that the CPR coach is in place, they should verbalize the data from the feedback device, providing corrective and positive feedback, such as push harder or your rate is good.
Great job. You're right on target.
In addition to giving corrective feedback, CPR coaches should give mid-range targets so that providers can focus on a precise metric. An example of this would be coaching the compressor to target a rate of 110 compressions per minute, taking the average between the recommended range of 100 to 120 compressions per minute.
And now you're too fast. Target heart rate is 110.
The CPR coach should also coordinate the initiation of CPR and pauses in CPR. These actions can include initiating CPR, placing a CPR board if needed, analyzing the rhythm, switching compressors, defibrillating, or intubating the patient. The goal of the coach is to keep all pauses to 5 seconds or less when possible.
Switch.
Okay, that VF, go ahead
Hover.
and chart and shock.
Clear. Shock. Resume.
Except for intubation. Intubation should be performed by skilled providers, ideally without stopping compressions.
Okay, through the cords.
But if it's necessary to pause for intubation, the pause must be for 10 seconds or less.
I'm still having trouble. Go ahead and pause CPR. Okay, there we go. Through the cords. Continue.
If intubation can't be accomplished in 10 seconds or less, the team should continue compressions with bag mask ventilation. Being an effective CPR coach takes practice and training. If you'd like to learn more about how you can incorporate the CPR coach role into your resuscitation team, please ask your instructor for more information.
Yeah. Secret objects. Questions. What should be the primary focus of the CPR coach on a resuscitation team? Quality. Ensure high quality CPR. Document, resolve team arguments. CPR coach role can be blended into which of the following roles? Defibrillator. And I like standing at the defibrillator and like following what the doctor says and just like programming it in and watching the rhythm while somebody does airway and someone else is on meds and someone's doing compressions. That's nice. I've been in codes where there's been like 2 or 3 sets of hands. That sucks. Okay, but we get it done. What are you gonna do? You can do what you can do. However, you got to know how to do this. Okay. Let's teach. All right. Hello. Me teaching. Can I teach ACLS? I learn by teaching. And so if I'm going to be really good at ACLS, I might as well get paid to teach it, right? Who would pay me to teach them ACLS? Raise your hand. Brave leadership. Yes. Hello. All right. Questions. Which of the following is a responsibility of the CPR coach? Assisting with IO placement, coordinating compressor switches, not choosing the medications, not inquiring about event summaries. Who's doing that right now? Coordinating switches is the role of the coach.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The foundation for resuscitation of cardiac arrest patients is high-quality basic life support. It's critical that you successfully perform these skills because effective advanced cardiovascular life support depends on them. These skills help save lives. High-quality CPR maintains blood flow to vital organs, especially the heart and brain. The components of high-quality CPR include adequate compression depth. Remember to push hard, compressing at a depth of at least 2 inches. Make sure you position your body over the patient. Good body position, with the shoulders serving as the fulcrum over the chest, will help you use your own body weight to perform compressions. Consider a step stool if necessary to achieve this position. If the person is not on a firm, flat surface, consider inserting a short board beneath them. Adequate compression rate. It is important to push fast by compressing at a rate of 100 to 120 compressions per minute, allowing complete chest recoil between compressions, minimizing interruptions in compressions. Healthcare providers must minimize interruptions in chest compressions. This includes any pauses to deliver ventilations. When healthcare providers interrupt chest compressions, coronary perfusion pressure decreases dramatically and remains very low until compressions are resumed. It takes several compressions to build enough pressure to achieve an adequate coronary perfusion pressure necessary to get ROSC. And finally, avoiding excessive ventilation. The AHA requires the use of audio-visual feedback and prompt devices during a training practice and testing, and highly recommends use during real emergencies for real-time monitoring of CPR quality. The first skill we'll demonstrate is performing continuous chest compressions for 2 minutes.
Sweet. Okay. Oh, part 2.
So, let's build on these skills. We'll now illustrate 2 healthcare providers assessing and performing high-quality BLS, including the use of an AED.
The scene is safe. Are you okay? Are you okay? We need more help. Call for backup and bring the defib.
Check a carotid pulse.
No pulse.
Not across.
He's not breathing.
Do it on your side. Chest compressions. Pump that heart. You gotta keep up with it. And I do like feedback devices. They're nice. And usually you just hook it up to the defibrillator.
Attach pads to patient's bare chest.
That's an AED.
Plug in pads connector.
I don't know if other AEDs with
Analyzing heart
Clear.
rhythm. Do not touch the patient. Shock needed.
So all
Charging.
clear. All clear.
Stay clear of patient.
Clear.
Deliver shock now.
And I'm a
Shock
I'm a
delivery.
hyper communicator.
In summary, perform high-quality CPR by compressing at a depth of at least 2
in
inches
the trauma
and at a
bay.
rate of 100 to
Make
120
sure
per
everybody
minute,
hears everybody.
allowing complete chest recoil, minimizing interruptions and compressions, and avoiding excessive ventilation. Additional measures, such as switching
Oh, I can't wait
compressors
to get
every
back to
2
ER
minutes
nursing. I'm
or
so
earlier if
excited.
fatigued, and using an audio-visual feedback device to improve CPR quality in
Makes
real
me happy.
time will help give patients
know
the
it's
best chance for
Terrible for my
survival.
nervous system. Here we go. Okie dokie. What's the recommended compression rate for high quality CPR? 100 to 120, which is the fastest on here. Which best describes the length of time it should take to perform a pulse check during the BLS assessment? 5 to 10 seconds. Quick. It's quick. You should be able to find this on anybody. Which is a component of high quality CPR? Depth of at least 2 inches, switching compressors every 2 minutes, compression rate of about 10 per minute. 10 per minute? What? You're going to kill somebody. Defibrillation at maximum energy. You're going to kill somebody. Which component of high quality CPR directly affects chest compression fraction? Chest recoil, compression depth. Interruptions. Because chest compression fraction is the fraction of time you're doing chest compressions, which needs to be 80 or above, which is usually really too low. People need to hop in and do chest compressions. You better keep on that heart. Interruptions. You are literally the pulse of that person. If you stop, the pulse stops. Okay.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Managing a patient's airway is a fundamental life-saving skill, one that both basic and advanced healthcare providers should be able to perform well. Airway management is one of the key interventions for BLS and ACLS. It is critical before, during, and after cardiac arrest. The optimal method of managing the airway will vary based on provider experience, training, scope of practice, EMS or healthcare system protocols, and the patient's condition. When giving ventilations, healthcare providers should avoid excessive ventilation or administering tidal volumes that are too large. Not only can this cause gastric insufflation and aspiration of gastric contents, but excessive ventilation also increases intrathoracic pressure and decreases venous return to the heart. So it lowers cardiac output and the patient's chance of survival. Tidal volumes should be approximately 500 to 600 milliliters, enough to see the chest rise. This is about half the squeeze of an adult ventilation bag. Once the airway is open and clear, you may consider use of an airway adjunct to maintain a patent airway. There are 2 types of airway adjuncts: the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious, semi-conscious, or unconscious patients with or without a gag reflex. The OPA is a J-shaped, single-use disposable plastic device. Here's how to choose the correct size OPA. Place the OPA against the patient's cheek. When the flange of the OPA is at the corner of the mouth, the tip is at the angle of the mandible. A properly sized and inserted OPA results in proper alignment with the glottic opening. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. It also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. The NPA is a soft, curved, hollow tube that can be inserted through the nostril to facilitate ventilation and suctioning. Unlike oral airways, NPAs may be used in patients who are conscious, semi-conscious, or unconscious, with or without a gag reflex. In choosing the correct size, make sure that the length of the NPA is the same as the distance from the tip of the patient's nose to the earlobe. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilation and suctioning. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds. During resuscitation, patient ventilation is commonly provided with a bag mask device. Now, let's see how to properly use a bag mask device. First, position yourself directly at the top of the patient's head. Place the mask over the patient's face. Before providing bag mask ventilation, the provider must first perform a head tilt and then press the mask against the face while lifting the jaw into the mask. This is best achieved by forming a C with the index finger and thumb of one hand on the top side of the mask at the bridge of the nose. This motion firmly secures the mask to the face. At the same time, the three remaining fingers form an E and should be used to lift the jaw, opening the airway. While maintaining a tight seal between the patient's face and the mask, and maintaining a jaw lift to open the airway, the provider should squeeze the bag, taking about 1 second to deliver one breath. For a patient who has spontaneous circulation but needs ventilatory support, the provider should give rescue breaths at a rate of 1 breath every 6 seconds. An effective breath results in visible chest rise. The most effective way to deliver bag mask ventilation is to use the two-person technique. The first provider focuses on keeping the airway open and securing the mask, while the second provider delivers ventilation with the bag. The first provider uses both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C, ensuring a good mask seal against the face, with the three remaining fingers of each hand forming the E, lifting both sides of the jaw into the mask. The second provider squeezes the bag, enough to cause visible chest rise. The American Heart Association recommends using waveform capnography with a bag mask device to provide increased monitoring of ventilations and CPR quality. Effective ventilation through these airway devices should produce a capnography waveform. There are several possible indications for insertion of an advanced airway. These include difficulty providing effective bag mask ventilation, patients with actual or potential airway compromise, particularly with long transport times, or the need to isolate the airway. Healthcare providers who use advanced airways within their scope of practice must maintain their skills by using them frequently. When choosing to use an advanced airway, you need to be confident that it is inserted correctly and that you're providing effective ventilation while avoiding excessive ventilation. Watching for chest rise, checking for bilateral breath sounds, and listening for gurgling sounds coming from the stomach can help you confirm the placement of an advanced airway. Beyond these clinical assessments, there are several devices that can help you determine whether you have inserted the airway correctly. Waveform capnography monitors how much carbon dioxide is exhaled by the patient. The American Heart Association recommends using waveform capnography to confirm and monitor the correct placement of an endotracheal tube. Effective ventilation through supraglottic airway devices should produce a capnography waveform. A normal end-tidal CO2 waveform looks like this. The measurement of the amount of end-tidal, or exhaled, carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to zero when we inhale. Even when healthcare providers are properly ventilating the patient, chest compressions will produce a low-end tidal CO2 reading because even the best CPR produces cardiac output and pulmonary blood flow that's about 25 to 30% of normal. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Waveform capnography devices that display both a waveform and a number will give you the most comprehensive information. Humans with healthy lungs have a characteristic waveform that is divided into 4 phases that occur during inspiration and expiration. When the patient first begins to inhale, the curve falls sharply to 0. As the patient continues to inhale, the reading on the monitor should remain at 0. When the patient first exhales, the initial portion of the breath consists of the air in the dead space from the breathing tube and the trachea. As air from the alveoli begins to empty into the circuit, carbon dioxide levels start to increase. This is shown as an upward deflection at the beginning of the exhaled carbon dioxide curve. As exhalation continues, carbon dioxide continues to pour out of the lungs until the next breath is initiated. The highest value in the curve is called the end-tidal CO2. For patients with normal perfusion, an end-tidal CO2 reading of less than 35 millimeters of mercury indicates hyperventilation. A reading of more than 45 suggests hypoventilation. Sudden changes in the waveform should trigger immediate reassessment of the patient. When the waveform jumps up during resuscitation, this may indicate ROSC. Airway skills are fundamental to successful ACLS. Proper training, frequent practice and use, and logging both successes and complications can help build your skills and lead to more comprehensive, successful patient care.
It's $500 a night for the whole place. It's a family retreat. Split it with friends, or take it as like a quiet place to yourself.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Managing a patient's airway is a fundamental life-saving skill, one that both basic and advanced healthcare providers should be able to perform well. Airway management is one of the key interventions for BLS and ACLS. It is critical before, during, and after cardiac arrest. The optimal method of managing the airway will vary based on provider experience, training, scope of practice, EMS or healthcare system protocols, and the patient's condition. When giving ventilations, healthcare providers should avoid excessive ventilation or administering tidal volumes that are too large. Not only can this cause gastric insufflation and aspiration of gastric contents, but excessive ventilation also increases intrathoracic pressure and decreases venous return to the heart. So it lowers cardiac output and the patient's chance of survival. Tidal volumes should be approximately 500 to 600 milliliters, enough to see the chest rise. This is about half a squeeze of an adult ventilation bag. Once the airway is open and clear, you may consider use of an airway adjunct to maintain a patent airway. There are two types of airway adjuncts: the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious, semi-conscious, or unconscious patients with or without a gag reflex. The OPA is a J-shaped, single-use disposable plastic device. Here's how to choose the correct size OPA. Place the OPA against the patient's cheek. When the flange of the OPA is at the corner of the mouth, the tip is at the angle of the mandible. A properly sized and inserted OPA results in proper alignment with the glottic opening. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. It also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. The NPA is a soft, curved, hollow tube that can be inserted through the nostril to facilitate ventilation and suctioning. Unlike oral airways, NPAs may be used in patients who are conscious, semi-conscious, or unconscious, with or without a gag reflex. In choosing the correct size, make sure that the length of the NPA is the same as the distance from the tip of the patient's nose to the earlobe. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilation and suctioning. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds. During resuscitation, patient ventilation is commonly provided with a bag mask device. Now, let's see how to properly use a bag mask device. First, position yourself directly at the top of the patient's head. Place the mask over the patient's face. Before providing bag mask ventilation, the provider must first perform a head tilt and then press the mask against the face while lifting the jaw into the mask. This is best achieved by forming a C with the index finger and thumb of one hand on the top side of the mask at the bridge of the nose. This motion firmly secures the mask to the face. At the same time, the three remaining fingers form an E and should be used to lift the jaw, opening the airway. While maintaining a tight seal between the patient's face and the mask, and maintaining a jaw lift to open the airway, the provider should squeeze the bag, taking about 1 second to deliver one breath. For a patient who has spontaneous circulation but needs ventilatory support, the provider should give rescue breaths at a rate of 1 breath every 6 seconds. An effective breath results in visible chest rise. The most effective way to deliver bag mask ventilation is to use the two-person technique. The first provider focuses on keeping the airway open and securing the mask, while the second provider delivers ventilation with the bag. The first provider uses both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C, ensuring a good mask seal against the face, with the 3 remaining fingers of each hand forming the E, lifting both sides of the jaw into the mask. The second provider squeezes the bag, enough to cause visible chest rise. The American Heart Association recommends using waveform capnography with a bag mask device to provide increased monitoring of ventilations and CPR quality. Effective ventilation through these airway devices should produce a capnography waveform. There are several possible indications for insertion of an advanced airway. These include difficulty providing effective bag mask ventilation, patients with actual or potential airway compromise, particularly with long transport times, or the need to isolate the airway. Healthcare providers who use advanced airways within their scope of practice must maintain their skills by using them frequently. When choosing to use an advanced airway, you need to be confident that it is inserted correctly and that you're providing effective ventilation while avoiding excessive ventilation. Watching for chest rise, checking for bilateral breath sounds, and listening for gurgling sounds coming from the stomach can help you confirm the placement of an advanced airway. Beyond these clinical assessments, there are several devices that can help you determine whether you have inserted the airway correctly. Waveform capnography monitors how much carbon dioxide is exhaled by the patient. The American Heart Association recommends using waveform capnography to confirm and monitor the correct placement of an endotracheal tube. Effective ventilation through supraglottic airway devices should produce a capnography waveform. A normal end-tidal CO2 waveform looks like this. The measurement of the amount of end-tidal, or exhaled, carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to 0 when we inhale. Even when healthcare providers are properly ventilating the patient, chest compressions will produce a low end-tidal CO2 reading because even the best CPR produces cardiac output and pulmonary blood flow that's about 25 to 30% of normal. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Waveform capnography devices that display both a waveform and a number will give you the most comprehensive information. Humans with healthy lungs have a characteristic waveform that is divided into 4 phases that occur during inspiration and expiration. When the patient first begins to inhale, the curve falls sharply to 0. As the patient continues to inhale, the reading on the monitor should remain at 0. When the patient first exhales, the initial portion of the breath consists of the air in the dead space from the breathing tube and the trachea. As air from the alveoli begins to empty into the circuit, carbon dioxide levels start to increase. This is shown as an upward deflection at the beginning of the exhaled carbon dioxide curve. As exhalation continues, carbon dioxide continues to pour out of the lungs until the next breath is initiated. The highest value in the curve is called the end-tidal CO2. For patients with normal perfusion, an end-tidal CO2 reading of less than 35 millimeters of mercury indicates hyperventilation. A reading of more than 45 suggests hypoventilation. Sudden changes in the waveform should trigger immediate reassessment of the patient.
Yes.
When the waveform jumps up during resuscitation, this may indicate ROSC. Airway skills are fundamental to successful ACLS. Proper training, frequent practice and use, and logging both successes and complications can help build your skills and lead to more comprehensive, successful patient care.
Patient care. Let's see. To properly ventilate a patient with a perfusing rhythm, how often do you squeeze the bag? Once every 6 seconds. Which is an acceptable method of selecting an appropriately sized oral pharyngeal airway? So, mouth to mandible, nostril to earlobe. Mouth to mandible, nostril, earlobe. Measure from the corner of the mouth to the angle of the mandible. Which action is likely to cause air to enter the victim's stomach during bag mask ventilation more than 6 seconds? Ventilating too quickly. What are the other options? Giving breaths over 1 second, providing just enough volume for the chest to rise, providing a good seal between the face and the mask. Giving breaths over 1 second, 1 Mississippi. You want to provide just enough volume for the chest to rise. You want to go 1 Mississippi until the chest rises, and then you let go. Providing a good seal between the face and the mask is what you got to do too. So ventilating too quickly puts air in the stomach. It's not pretty. In addition to clinical assessment, which is the most reliable method to confirm and monitor correct placement of an endotracheal tube. What's the most reliable method? Continuous waveform capnography. I mean, the most reliable method is a chest x-ray. What? Waveform capnography.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves.
Yes.
Often, nurses, physicians, or family members who are concerned that a patient is deteriorating can activate the rapid response system in the hospital. Also, paramedics, using critical thinking skills, can act on signs of clinical deterioration by treating the patient and rapidly transporting the patient to the emergency department.
Yes, sir.
Some rapid response systems weigh, combine, and score specific physiologic criteria to determine when to act. The following list gives examples of such criteria for adult patients. Threatened airway, respiratory rate less than 6 or greater than 30 breaths per minute, heart rate less than 40 or greater than 140 per minute, systolic blood pressure less than 90 millimeters of mercury, symptomatic hypertension, unexpected decrease in level of consciousness, unexplained agitation, seizure, significant decrease in urine output, and subjective concern about the patient.
I love that they made sure of that, for sure. What are the 3 signs of clinical deterioration that would cause activation of a rapid response system? Shortness of breath, unexplained agitation, systolic blood pressure of less than 90 milligrams. Milliliters, square millimeters of mercury. Incorrect. Unexplained agitation and seizure. There. Symptomatic hypertension. Unexplained agitation, seizure is embolism. What's the purpose of a rapid response team or a medical emergency team? To identify and treat early clinical deterioration. Boop-a-da-boop.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves.
Leticia,
Hey, Jack, what's up?
happy Monday. When you finish with this, I need you to clear off the end cap down there. I got a whole bunch of promotional items coming in. We got to put them somewhere.
Okay, sounds good.
Oh,
You all right, Jack?
yeah. Yeah, I'm fine. I think it's that stuff that everybody's got going around.
Okay.
Acute coronary syndromes, or ACS, may suddenly strike men and women, often after years of asymptomatic coronary atherosclerosis and plaque formation. As plaque forms within the coronary arteries, several clinical syndromes may also develop, with varying degrees of coronary artery occlusion. Two of these syndromes are non-ST segment elevation acute coronary syndromes, or NSTE-ACS, and ST segment elevation myocardial infarction, or STEMI. STEMI is generally considered to be more serious and usually develops after a ruptured plaque or an erosion results in an acute blood clot that significantly or completely occludes a coronary artery. Either of these syndromes can, unfortunately, manifest as sudden cardiac arrest and death. It's estimated that half of the deaths from these syndromes occur outside the hospital, making early recognition and rapid response essential. The best outcomes from ACS occur in communities where programs with strong public education, PAD programs, and STEMI systems of care exist. Watch how emergency medical services and hospital personnel use the STEMI chain of survival to provide a system of care that recognizes and rapidly treats the underlying causes of ACS.
What's going on?
I think Jack's having a heart attack. I'm going to call 911. You get the AED and first aid kit.
Okay.
911, what is your emergency?
I think my manager's having a heart attack.
I see you're located at 459 Commerce Avenue, is that correct?
Yes.
Where is the patient?
He's right here. He was wobbly on his feet, so we sat him down in the aisle. He's having chest pains and his left arm hurts.
Is he awake? Can you talk to him?
Yes, he's awake and able to talk.
I'm going to dispatch paramedics to your location. Stay on the line with me, okay? Don't hang up. I'll have a few more questions to ask you.
Okay.
The first step in the ACS algorithm involves the patient, bystanders, and medical personnel recognizing the warning signs of cardiac ischemia.
We all had basic first aid training and CPR training about 6 months ago. And when Jack said his chest was hurting and his left arm was hurting, that's when the alarm bells went off for me.
Our system uses priority dispatching protocols, which help identify the problem and determine what type of response to send. What the caller described fit the protocol for ACS, which required a high priority EMS response.
While waiting for EMS to arrive, dispatchers may advise patients to chew 162 to 325 milligrams of non-enteric coated aspirin. This recommendation should be in line with approved medical protocols, and only if the patient has no history of true aspirin allergy or gastrointestinal bleeding.
Okay, paramedics are on their way. Stay on the line with me until they arrive. Do you have a first aid kit with you?
Yes, and I have our AED too.
Great. Is the patient still conscious?
Yes, he is.
Okay, then we won't need to use the AED right now. Ask if he has an aspirin allergy or any recent bleeding from his stomach.
Jack, do you have an allergy to aspirin?
No,
Have you had any bleeding in your stomach recently?
no, I don't think so. No.
No to both questions.
Look in the first aid kit. If it has aspirin, have him chew 2 to 4 baby aspirins or 1 adult aspirin while you wait for the paramedics to arrive.
That brings us to the next step in the ACS algorithm: assessment, care, and hospital preparation.
What happened?
He's been having chest pains for about 10 minutes. The 911 operator said to give him an adult aspirin to chew.
Sir, how you feeling?
Not so good. It's my chest. I feel like somebody's squeezing it.
Okay. Well, we're going to help you out, reduce that pain. I'm going to get a 12 lead. Go ahead and get his blood pressure and put him on a pulse ox. When we arrive on scene, the clock is ticking. I know I've got to assess, but if he doesn't need immediate resuscitation, my highest priority is to obtain a 12-lead ECG, manage the symptoms, initiate transport as soon as possible. Every minute matters. The longer it takes to get to the hospital, the poorer the outcome for the patient. In fact, half the people who die from ACS are dead before they even reach the hospital. So I follow the ACS algorithm closely just to make sure that doesn't happen.
Administer supplementary oxygen if the patient's oxygen saturation value is less than 90%. Give aspirin if the patient hasn't taken any yet and there are no contraindications. It's critical that out-of-hospital healthcare providers obtain a 12-lead electrocardiogram.
Looks like a STEMI.
This early ECG helps classify patients suspected of having an ACS into 2 groups based on ST segment deviation before they reach the hospital. It's preferred that patients with ST segment elevation be driven, if feasible, to a hospital that performs primary PCI. This initial ECG speeds the patient's diagnosis and shortens the time to reperfusion.
Recognizing ST segment elevation on a 12-lead ECG takes training and practice because different thresholds exist for patients depending on their age and gender.
If a STEMI is suspected, EMS should notify the hospital or transmit the ECG for interpretation.
The patient had ongoing symptoms of ischemia, so we administered nitroglycerin sprays every 3 to 5 minutes for a total of 2 doses. 3 is the max. We monitored the patient's blood pressure in between each dose.
Before giving nitrates in any form, make sure there are no contraindications, such as severe bradycardia, tachycardia, or hypotension. Also, confirm that the patient hasn't taken any phosphodiesterase inhibitors for erectile dysfunction in the past 24 to 48 hours. Patients with inferior wall STEMI on their 12-lead ECG can often have right ventricular involvement. This can be confirmed by a right-sided 12-lead. If RV infarction is present or suspected, nitrates in all forms are contraindicated. Clinically, it may be suspected in patients with hypotension, clear lungs, and elevated JVD. If the patient receives nitroglycerin but does not experience pain relief, healthcare providers can consider giving analgesics, such as morphine, while monitoring the patient's blood pressure and respiratory rate. Use morphine with caution for patients with unstable angina.
County Medical, this is Rescue 1. We've got a STEMI alert. 46-year-old male, chest discomfort started half an hour ago. Current vital signs are BP 104/78 with a heart rate of 96. Pulse ox 95%. He's chewed 325 milligrams of aspirin and received 2 rounds of nitroglycerin sprays, but still says he has chest discomfort. 12 lead shows ST segment elevation of 3 to 4 millimeters in leads V1 through V4. ETA to your facility is 10 minutes.
Rescue 1, we received your 12 lead and your initial report. We'll activate our heart alert system, contact the cardiologist and the cardiac cath team.
Getting this advance notice really helps us speed treatment of these patients, increasing their chance of survival. We can have the cath lab prepped and ready by the time the patient hits the doors of the ED.
The American Heart Association recommends that EMS personnel transport patients who have a STEMI to the closest appropriate facility that provides reperfusion without delay. Based on hospital local protocol and cath lab team being prepped and in place, it is best practice to bypass the ED and take the patient straight to the cath lab where initial evaluation can take place.
Studies show that ED evaluations are responsible for as much as 33% of the total time from symptom onset to treatment. We try to reduce delays by having everything ready when the medics arrive. After seeing the 12 lead that the medics had sent, I immediately activated a PCI team and alerted the cardiologist.
When the patient arrives at the ED, we move to the next step in the ACS algorithm. Reperfusion goals for STEMI patients include PCI within 90 minutes after the first medical contact, or fibrinolytics within 30 minutes from ED arrival. The appropriate therapy is defined by patient and center criteria. Within the first 10 minutes after arrival, staff should provide an immediate assessment of the patient. That includes taking vital signs, getting a brief, targeted medical history, completing a fibrinolytic checklist, and obtaining blood studies. If the early ECG shows no signs of ST segment elevation, then a repeat ECG in the ED is warranted. The staff should also get a chest X-ray within the first 30 minutes after arrival. In addition, draw a STEMI panel. Adjunctive treatments include unfractionated or low molecular weight heparin, bivalirudin, P2Y12 inhibitors, IV nitroglycerin, beta blockers, and glycoprotein 2B3A inhibitors.
Hi, I'm Dr. Taylor.
Hi, how is he? Did he have a heart attack?
I'm afraid so, but his vitals are improving. Dr. Abrams is an excellent cardiologist, and he'll be going over the next steps with you.
Okay,
You'll be in good hands with him, okay?
thank you.
This patient presented with ST segment elevation of 3 to 4 millimeters in leads V1 through V4. Now, this suggests that his LAD artery is occluded. Immediately opening up the artery with PCI and restoring normal blood flow is my primary goal.
The final link in the STEMI chain of survival is treatment. The preferred reperfusion strategy for STEMI patients is PCI.
Hi, Mr. Brennan. I'm Dr. Abrams, your cardiologist. How are you feeling?
Not so good.
Well, hopefully you'll be feeling a lot better soon. I just want to talk to you a little bit about what's going on. I reviewed your ECG, and it appears you have a blockage in one of the arteries to your heart. Now, to open the artery, we need to perform a procedure called PCI that'll help reestablish blood flow to your heart. Basically, we insert a catheter into the artery with the blockage and inflate a balloon to widen the blocked area. We then place a stent to keep the artery open. And the sooner we can do this procedure, the less damage may be done to your heart. Okay?
Okay. I understand. I'm ready.
All right. Let's see what we can do to help you get better, okay? All right.
What is the initial drug therapy for acute coronary syndrome? Oxygen if needed, aspirin, nitro, morphine. A patient without dyspnea has signs of acute coronary. There's no obvious signs of heart failure. You assess a non-invasively monitored oxyhemoglobin saturation. Which patient should receive supplemental oxygen? 100%. So you can't give it in an inferior right ventricle infarction.
PCI opens the blocked artery with a tiny balloon. Then a stent, or metal scaffold, is inserted to maintain blood flow to the heart. When choosing between this reperfusion strategy and fibrinolytic therapy, hospital personnel must consider a number of factors. Studies show that treatment delays increase mortality in both groups, regardless of the reperfusion strategy chosen, but were more pronounced among those patients receiving fibrinolytic drugs. In these cases, the more time that goes by, the more heart muscle is lost. The better EMS systems and medical centers work together, and the faster they can deliver treatment, the more heart muscle and patients can be saved.
We had a great outcome with that patient, but we wouldn't have if every link in the chain hadn't been working cohesively.
All the pieces fit together perfectly, and it all began with a call from his coworker. The dispatcher assisted in the administration of aspirin prior to our arrival. We were able to get to him in time, identify a STEMI, and move him quickly to a hospital where they were ready to do PCI. He's back at work today because of it.
Stroke.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Stroke is a leading cause of death and the #1 cause of disability among adults in the United States. We're going to demonstrate how to quickly recognize the telltale symptoms of acute ischemic stroke and model how to respond promptly and with appropriate care and treatment. First, let's review the pathophysiology. A stroke occurs when blood flow to the brain is interrupted, either by a clot, called an ischemic stroke, or when a blood vessel ruptures, called a hemorrhagic stroke. 87% of all strokes in the United States are ischemic. This type of stroke occurs when plaque due to atherosclerosis collects along the walls of the arteries, narrowing the arteries leading to or lying within the brain. As in the coronary arteries, disruption of the vessel wall can cause a clot to form, further narrowing or even occluding the artery. Pieces of clot can break off and travel deeper into the arteries and eventually lodge in a smaller vessel in the brain and cause a stroke there. This interruption in blood flow ceases function in the affected brain tissue, leading to a sudden onset of symptoms. Brain injury can be minimized and fatalities can be avoided when family members and healthcare providers use the stroke algorithm and follow both the stroke chain of survival and the 8 Ds of stroke care. When a stroke occurs, the stroke chain of survival suggests the following actions: rapid recognition and reaction to stroke warning signs, rapid EMS dispatch, rapid EMS system transport and pre-arrival notification to the receiving hospital, and rapid diagnosis and treatment in the hospital. The 8 Ds of stroke care act in coordination with the chain of survival. As our case study reveals, it's essential that family and healthcare providers follow these steps and work together to rapidly recognize and treat acute ischemic stroke. As you'll see, time is brain. Because many strokes occur at home, it's essential that family members recognize the signs of a stroke and promptly call for help.
It all happened so quickly. 1 minute she was fine, and then the next minute she just fell over. Ellie, honey, what's wrong? Talk to me. It's okay. I'm gonna call 911. Something's wrong. Her mouth was drooping. She couldn't speak. The whole right side of her body just went limp. Immediately, I called 911.
As you can see, the first crucial step in the stroke chain of survival is activating the emergency response system. This is also the first D in the 8 Ds of stroke care: detection of symptoms.
What are the major types of stroke? Hemorrhagic and ischemic. What's the most common type of stroke? Ischemic.
Rescue 21 respond. 3326 Davis Lane, possible CBA.
Rescue 21, copy.
You're responding to a 45-year-old female with notable weakness to the right side and facial droop.
The second link in the stroke chain of survival is rapid EMS dispatch. This is also the second D in the 8 Ds of stroke care.
Strokes receive a high dispatch priority, and we try to get there as quickly as possible. Part of the reason to get to them quickly is in case there's a life-threatening problem, but another part is to get them to a stroke hospital where fibrinolytic treatment can be administered and possibly reverse the damage.
They're here.
Hi, Mrs. Vega. We're going to help you out. Eddie's going to take your vitals, and I'm going to ask a few questions.
Well, the first thing I want to do is rule out any other possible causes for the patient's condition. I discovered Mrs. Vega wasn't experiencing any chest or back pain, and she wasn't having any trouble breathing. Mr. Vega also informed us that she didn't have any history of diabetes or seizures. And to rule out hypoglycemia, we did a quick finger stick blood glucose analysis. It was fine. I also confirmed she's not on any blood thinners.
EMS should also test the neurologic condition of the patient with a stroke assessment, such as the Cincinnati Pre-Hospital Stroke Scale.
Mrs. Vega, can you smile for me?
Okay, Mrs. Vega. Try to close your eyes. I want you to hold your hands out front. Okay. Mrs. Vega, I want you to repeat something for me. Can you say, you can't teach an old dog new tricks?
You can't teach dog.
The stroke test definitely showed key abnormal indicators, strong signs of a possible stroke. And Mr. Vega informed us that the symptoms had started 20 minutes before we arrived. I knew I had to make decisions quickly.
To help identify which hospital is most appropriate for the stroke patient, EMS should also perform a severity screen to indicate if there is a possible large vessel occlusion. As always, EMS should follow local stroke protocols.
What are her vitals?
Blood pressure is 190 over 110, heart rate's 110, respirations are at 14, her pulse ox is 95.
Her blood pressure was elevated, but her oxygen saturation was normal. Mr. Vega, we think your wife is having a stroke. We'll need you to come with us to County Medical. They're specially equipped to handle the situation. The sooner we get there, the better.
Good. Happened so fast. The EMS team had her checked out in 10 minutes. And they even let me ride in the back, keep her calm and answer any questions.
The third link in the stroke chain of survival is rapid EMS transport to a hospital that is equipped to deal with acute stroke. This is also the third D of the 8 Ds of stroke care, delivery of the patient by rapid EMS transport.
Rescue 21, go ahead.
We are en route with a possible stroke patient, a 45-year-old female with weakness on right side, facial droop on right side, and difficulty speaking. While we were en route to the stroke center, I radioed ahead so that the stroke team could be fully prepared once we arrived. Patient's blood pressure is 190 over 110. Her heart rate is 110, and her respiratory rate is 14 without difficulty breathing. Patient's blood glucose level and pulse oximetry readings are within normal limits. The patient's ECG shows sinus tachycardia without ectopy, and according to family members, the first onset of symptoms was approximately 23 minutes ago, 11 a.m., and we have an estimated time of arrival of 5 minutes.
Received, Rescue 21. We'll be ready. Let's activate our stroke team. There is a limited window of opportunity to evaluate the patient and determine eligibility for fibrinolytics and start the drugs. Getting that advance notice from EMS allows me to notify the stroke team so that they're poised to respond when that patient arrives.
The fourth D of stroke care is DOOR. DOOR stands for the effective triage of the patient. The initial evaluation should include assessment of the patient's ABCs, airway, breathing, and circulation. Hospital personnel should administer oxygen if the patient becomes hypoxemic while en route. It is best practice to bypass the ED and take the patient straight to the CT or MRI suite. Hospital personnel should assess a patient with a suspected stroke within 10 minutes after the patient's arrival in the ED, CT suite, or MRI suite. Follow your local protocol. Confirm IV patency and draw blood samples for blood glucose, electrolyte, CBC, and coagulation studies. Even though EMS did a fingerstick blood glucose analysis, hospital personnel should review and verify blood glucose results. Hospital personnel should also acquire a 12-lead ECG, which may identify a recent myocardial infarction or arrhythmia as a potential cause of the stroke. The next step in the 8 Ds of stroke care involves the collection of data. Ideally, within the first 20 minutes of a suspected stroke patient's arrival.
I get her history, perform a general physical examination, a neurologic examination, and establish the time of symptom onset. In this case, the first symptoms were about 45 minutes before. After asking a few questions and performing the NIH stroke scale, there were pretty clear indicators of a stroke. Since EMS had called ahead on their way to us, we already had our neurologist standing by.
Now, you have to remember the clock is ticking. So that means that you must evaluate the scan immediately. Now, our benchmark is that should happen within 45 minutes of the patient's arrival. The CT scan will help me determine if an intracranial hemorrhage is present. Now, if a hemorrhage is present, then our stroke team is going to pursue an entirely different path of treatment. On the other hand, if I find a normal CT scan, as in this case, that suggests an acute ischemic stroke is causing the patient's symptoms.
That brings us to the final link in the stroke chain of survival: rapid diagnosis and treatment in a hospital equipped for acute stroke patients. This is also the 6th D in stroke care: decision regarding treatment. In addition to IV fibrinolytics, endovascular therapy is recommended for large vessel occlusion, or LVO, patients who meet inclusion and time criteria. In some cases, endovascular procedures may not be available. An interfacility transfer should take place for those that meet the criteria for endovascular therapy.
With an ischemic stroke, CT scans often look normal within the first few hours of symptom onset. In this case, the CT scan looked normal and there was no evidence of bleeding. Thankfully, we were well within the window of fibrinolytic therapy. But before I recommended that treatment, I performed another neurologic exam and I asked some questions that were part of the fibrinolytic checklist. The neurologic exam showed no improvement. But before recommending fibrinolytic therapy, I wanted to review the patient's records and to see if there was any pre-existing conditions that might interfere with the drug treatment. These include brain hemorrhage, prior stroke, abnormal blood vessels in the brain, recent bleeding anywhere, any history of blood clotting problems, recent surgery or accidents, or certain prescription medications. Now, I wasn't seeing any potential problems with the drug therapy. Nancy, what's her current BP?
It's 192/114.
Okay, your blood pressure is still a little bit high, so we're going to give you a drug to help bring that down, okay? Okay, let's give her 10 milligrams of labetalol and try to get her systolic blood pressure down to 185 and her diastolic down to 110. Now, we'll recheck in about 3 to 5 minutes. If it's still elevated, then we need to double it or consider an IV infusion. Let's don't waste time here.
Okay, right away.
Okay.
If the patient's medical history is acceptable, if the time of onset is generally less than 3 hours, and if the patient's current condition can be managed within suitable parameters, it's time to move to the next D of stroke care: drug and/or device.
Mrs. Vega, we'd like to recommend a medication to you that may break up the blood clot that's causing the stroke. But we'd like to talk to you about the potential risks of this medication so you can make an informed decision.
What kind of risks?
There is a small possibility of having a cerebral hemorrhage that's bleeding into the brain. Now, if this occurs, Mrs. Vega's situation could get worse or may even possibly be fatal.
Well, it's only a very small risk, actually, about 5%.
That's right, but you still need to consider it. Now, the upside to this is the drug treatment may break up the blood clot in the brain, potentially restoring or improving blood flow to the affected areas, and that's a good thing.
Studies show that the drug therapy can improve the chances of recovery by 30% if administered within the first 3 hours of the symptom onset.
Now, the window can be extended for some select patients to 4.5 hours, but Mrs. Vega will easily make the 3-hour window, and that's even better.
That number works for me. Sounds like it's worth the risk. Honey?
Okay. Nancy, based on her weight, let's administer our TPA according to our protocol.
Will do.
Okay, it's going to take us about an hour to give this medication to you through your IV.
I would do blood pressure and neuro checks every 15 minutes while she's taking the therapy. I'd also monitor her neurologic status.
Good. Looks like you're in good hands. I'll check back with you after the therapy.
window for the administration. 3 hours.
After starting IV alteplase, the patient should be moved to the cath lab for endovascular therapy if they meet the criteria for large vessel occlusion. Patients who do not meet the time criteria for IV fibrinolytics may be candidates for endovascular therapy up to 24 hours after last known normal. For optimal recovery, hospital personnel must carefully control the patient's blood glucose levels, temperature, and blood pressure. The final D in the 8 Ds of stroke care is disposition. This means rapidly admitting the patient to a stroke unit or critical care unit.
She'll be surrounded by a team of people who specialize in stroke. Statistics show that these specialty units provide best practices and not only increase her chances of survival, but really improve her outcome as well. With a little physical therapy and time on her side, she's likely to have a full recovery.
By rapidly recognizing the signs of acute stroke and preventing delay in diagnosis and treatment, you give the patient considerably higher chances for a full recovery.
Okay, we're going to pause at bradycardia.